Hello and welcome to this Q&A from the Fertility Alliance. Today we're going to be talking about endometriosis and we're joined by Raj Mathur, who is a consultant from Manchester and also a trustee of the Fertility Alliance. So welcome, Raj. I wanted to start by asking you, what actually is endometriosis?
Hello, Kate. It's really nice to be part of this recording. I'm so glad you're taking up this subject of endometriosis, which is so important for fertility patients. Um, so endometriosis is quite a complex condition, but the simplest way I think of understanding it is that it is a situation where the tissue that normally lives on the inside or the lining of the uterus of the womb develops in other parts of the body. So for instance, if it develops in the ovaries or around the fallopian tubes, so this is the tissue that would normally be in the uterus appearing for some reason and progressing and developing outside the uterus. And this can then lead to problems like like pain and infertility. And this whole thing is called endometriosis.
So how would you know if you've got it? What are the symptoms?
Now, this is actually a more difficult question than appears at first sight. And the reason for this is we don't know how many women actually have endometriosis, because you can have endometriosis and be completely without any symptoms. So you'd be completely asymptomatic, no pain. You might also be fertile, but you might still have endometriosis. So we don't know what proportion of women with endometriosis fall into that luckier group. But those who have symptoms will usually have painful symptoms. So typically it would be period pain, but it can also be pain on intercourse. It can be pain when the woman opens her bowels, or it can be pain when passing urine. And initially, when it starts, the pain can occur in episodes. It can come and go. It can be linked to your periods only. But as time passes, in many people, the severity of the pain increases, the duration of the pain increases, and it becomes more complex, more chronic, and more difficult to manage.
And do we know what causes it?
There are a lot of theories. A lot of research is going on at the moment to see if there is a genetic cause for it. And it does seem that there is some genetic predisposition to endometriosis, but that doesn't explain everybody. It is likely that the way endometriosis develops is that when you have a period, when the woman menstruates, there is also some flow of blood through the fallopian tubes into the tummy, into the cavity of the abdomen. And in some women who are prone to this for some reason, those cells that are shed into the abdomen can grow and develop in the abdomen, so around the ovaries or around the fallopian tubes. And we don't know what increases the chances of that happening, but that is probably what leads to endometriosis. It's certainly quite likely to be related to hormones because it is a disease of the reproductive years. So women between the ages typically of 17 and 43 are likely to suffer from endometriosis. It's unlikely to appear for the first time after the menopause. So clearly there is a hormonal connection. There's possibly also some kind of immunological connection because women with autoimmune diseases are a bit more likely to have endometriosis. And finally, there's also some situations where there is an obstruction to the flow of blood through the normal route, through the vagina. And, and that obstruction increases the chance of blood reaching the tummy, and that can lead to endometriosis. This isn't that common, but it does apply particularly to young women with a congenital abnormality in the uterus or vagina that prevents the blood from coming out.
And how is it diagnosed?
What is called the gold standard method, or the most reliable method for diagnosing endometriosis, is a procedure called laparoscopy. Now, this is done under general anesthetic, a full anesthetic with the woman asleep, and a telescope is inserted through the belly button into the tummy. And this allows the surgeon to have a direct look at the organs in the pelvis, particularly the ovaries, the fallopian tubes, and the uterus and the tissues around them. And endometriosis can be diagnosed by an experienced surgeon by directly looking down the laparoscope. In some people, a laparoscopy may be high risk or maybe too invasive. They may not want to have it. For them, there is the option of having an MRI scan. An MRI can give good information, particularly about the ovaries. And if there is deposits of endometriosis affecting the bowel. Um, and also there is now the option of a transvaginal ultrasound scan, which can in expert hands, it can also give quite a lot of diagnostic information. So these things, the scan and the MRI, they're not as invasive as a laparoscopy, but on the flip side, they're not as accurate. The laparoscopy is the most accurate.
And if you've got endometriosis, is there anything you can actually do to make it better yourself?
Very little, I think. There's very little that is in your control that you can do that would reverse endometriosis. Now, that doesn't mean that you can do absolutely nothing. Quite often, women with endometriosis might find that their symptoms are worse or their pain is worse with certain types of food. And that is quite commonly seen in clinical practice. So avoiding that type of food is likely to help your symptoms. Very often, endometriosis can be associated with conditions like irritable bowel syndrome. So getting those looked at and following the right kind of diet for IBS may also affect your endometriosis symptoms. Um, there are some supplements that are sold over the counter. Whether these make a difference is not clear from the research, but there is some research to support vitamin D supplements. It might improve the severity of pain. And also supplements called omega-3 fatty acids, which are present in fish oil. Those have been shown in some trials to improve the severity of pain in women with endometriosis.
And once people have actually been diagnosed, is endometriosis always going to affect fertility or still not necessarily?
Still not necessarily. And unfortunately, it's really hard to predict in women in whom it will and in those in whom it won't. But the best estimate is that only around half of women who have endometriosis will suffer from fertility problems. And for a number of them, they will suffer from fertility problems, but that doesn't mean that conception would be impossible. It might mean that they will take longer because their per month chance of conceiving is lower than it would be without endometriosis. It might mean that they need treatment, but the ultimate chance of having a baby should be quite good.
And what treatments would be appropriate for someone with endometriosis?
So if we are talking about endometriosis associated infertility, then it's reasonable to try on your own for some time unless you have very severe endometriosis, which can be diagnosed by laparoscopy, MRI, etc. And if you've got what is considered minimal or mild endometriosis, you might also hear the words stage 1 or stage 2. Then you have the option of trying on your own and expecting a slightly lower chance of conception, but nonetheless a decent chance. You could also have surgery if you have minimal or mild endometriosis, and surgery to treat that relatively small amount of endometriosis has been shown to improve your chances of conceiving naturally. But if that doesn't work, or if you have more severe endometriosis, stage 3, stage 4, what is called advanced or severe endometriosis, then in those cases, it has to be some form of IVF or in vitro fertilization.
That's brilliant, Raj. Thank you so much. Really interesting and really good summary of endometriosis. So thank you so much for joining us today.
Thank you. It's been a pleasure.